Welcome, everyone, to the Beauty and the Surgeon podcast. I'm Amy, a nutritional therapy counselor, and I'm here with Dr. Martin, a board-certified plastic and reconstructive surgeon. Dr. Martin, how are you doing?
Pretty good, Amy. How are you doing today?
I'm good. It's snowing today.
It's snowing, and we have a topic that we called breast implant controversies. It's a hot button topic.
It is. I mean, all things surrounding, I feel like breast implants are always a little bit heated is maybe not the right word, but salacious in a lot of ways. You know, it's definitely probably the most common surgery that people think about when they think about plastic surgery. I think they probably think about breast augmentation first, followed by really bad facelift. So it's something that there is a lot of buzz around.
And lips, the over-injected lips.
Over-injected lips.
Yeah.
I try not to think about that at all, ever. But these are definitely things that I feel like are either really misunderstood or very much underreported, and maybe things that women are afraid of, undereducated about, and that we can kind of hope shed some light on.
I think that it's a topic that's very important. I do think that some of the controversies don't have a lot of science behind it, but I do feel like there's real issues there, specifically with breast implants. Some of the problems that we have with them, albeit the number is small in comparison to all the people that do breast augmentation. So today what we're going to do is break it down. We're not going to hopefully do it in a way that is open and honest and really go through the information that we have. We're going to also be honest with you in regards to what we don't know. And there's a lot of things we don't know. Mm-hmm. And that's the real problem of all this. It
is. And a lot of that is kind of just an effect of the situation, meaning, you know, cosmetic surgery and plastic surgery is somewhat of a rogue, you know, subset of medicine in a lot of ways. It's not like there's a lot of governing over how you report adverse side effects and adverse events. Like a lot of those are reported back to the manufacturer. And of course, there's some financial incentive for the manufacturer not to maybe disclose those openly. So I think some of it is just that it's not well reported on, or was not historically
not.
On.
But the FDA's been a lot stronger with that lately in terms of what they've done to regulate implants. The second part of it is there's a lot of bad feelings that come from the 90s when silicone breast implants were taken off the market. And we still, as a society, as a culture, have not recovered from that, at least in the United States. You know, if you go to different countries, they have different viewpoints on implants, breast implants. It could be a lot more critical or a lot more open, and they just accept it. So, you know, I think that this is going to be helpful for anybody who's considering breast augmentation. It'll also be helpful for anyone who's had a breast augmentation and feels like they're having problems.
Absolutely.
Okay, let's get started. Breast augmentation, Amy. I didn't look up the numbers, but I think if I remember correctly from our episode on breast augmentation, it's the third most common procedure we do. Is that correct?
That is. And actually, we had those stats more recently from one of our podcasts. I can't remember which one, but it's
for women, obviously.
For women.
Third most common procedure we do. We have a great episode on breast augmentation. You should go back and listen to it. It talks about everything related to the surgery. You can go on our website, jasonmartinmd.com, and look at anything you want to know about breast augmentation. But specifically, breast augmentation takes a breast implant and it puts it in the breast area to improve the shape and to increase size. Very basic. You can put it above the pectoralis muscle. Okay,
so the middle picture.
If
you're watching this, it's the middle picture.
It's on YouTube, so that would be on Jason Martin MD's YouTube channel. That would be the middle picture on YouTube. But for those listening, basically the pectoralis major muscle is the muscle that is well formed on me.
Oh, proud like a pigeon.
Yeah, huh? Not really. So it would
busting out like 50 push-ups every morning.
When I wake up before surgery, all the time.
Good measure.
Before I see every patient, I do 50 push-ups. So the pectoralis major muscle is the weightlifter's muscle that you see on the chest, and you can put the implant above that muscle, so on the outside of it, or underneath it. Most often, people do it underneath the muscle. Sometimes we'll do it above the muscle, and we call that subglandular. So it's below the gland. The gland is the parts of the breast that have the ducts and make the milk and all the stuff you learned about in 6th grade biology, 5th grade biology.
Probably. Yeah.
4th grade biology?
No, that's too far.
Okay.
Too far.
My kids go to the Catholic school, so it's probably 8th grade for them.
I don't know. I was just like, do they learn that? Like 12th grade? You're graduating. Here's a picture of the human body.
Exactly. All right. So that's breast augmentation. And the issues that we've had with breast implants lately have primarily to do with the fact that the implant, once it's implanted, is how the body reacts to it.
And that's the case with anything you implant in the body. This is not specific. We're going to talk about things that specifically affect breast implants, but any type of implant, whether it's a hip replacement, an artificial knee, even like really tiny implants, can all have issues inherent to those specific type of implant and can just cause issues with your body's reaction to them, rejection, inflammation, other things that we'll talk about. So I don't want people to think that breast implants are somehow special in the sense that they can have, issues with those kinds of things within the body. Any implant can.
Right. Your body is made through evolution or whatever you believe to react to foreign objects that are within the body. And that's how, over time, that we've survived infections, impalement on things, being bit by a saber-toothed tiger, whatever happened, your body walls off that area and in hopes that it doesn't spread a problem into other parts of the body and it saves your life. That's a basic response to injury and infection. So the body doesn't know inherently, your brain does, but the body's immune system and the system that reacts to all this stuff doesn't know that, hey, this is the breast implant.
Just knows it's a foreign object.
This is here to make me look better.
Yeah.
It knows that it's a foreign object. The interesting part of all this is when you start thinking that people react differently to these objects. And in most cases, the numbers pan out, no matter what people read on the internet, is that in most cases, a lot of cases, people react just fine to these, right? They wall off around the implant, they heal okay, you go on with your life, and things are fine. The implant lasts whatever we say it lasts, 10 years, 15, 20 years, whatever that number is, you do fine. But there are cases, there definitely are people that don't either react well to the implant, they have problems like scar tissue around the implant, they have something even more serious that we'll talk about today, or even the implant doesn't do well inside. It can fail. The implant can actually rupture. So that's what we're going to talk about today. It's better if you're considering this surgery to empower yourself. That's like the tenets of this podcast, to educate yourself so you can have that transformation. And understanding the risks related to breast augmentation is part of that.
It is.
Unfortunately, in the field of plastic surgery, I would love to say that everyone is honest and straightforward and cares about education. It's usually not the case, because you're right. It's more of a outlier in the field of medicine. But it's not just plastic surgery where medicine has conflicts.
No, absolutely not.
There is a financial incentive throughout medicine that can be a problem.
And that's increasing.
Yep.
And just one side note, if you guys are interested in kind of geeking out a little bit and learning more about the inflammatory process, we do talk more about that in our podcast about research. We talk about that. So if you want to learn more about kind of the basic what happens during those stages of inflammation, it might be a good one to listen to.
Right, and this will be a review. They go hand in hand.
Yep.
That's why we did those podcasts around each other, or those episodes. All right, so you put a breast implant underneath the gland, above the muscle, or below the muscle, your body is going to react and form at least a small amount of scar tissue around the implant. That's normal. That's called a capsule, CAPSULE. If you're looking on YouTube, you can actually see an implant, and then on top of that implant, surrounding that implant, is this capsule, this tissue that your body has made to wall off this implant.
We should probably state for anybody who's watching this or want to watch that on YouTube, we are showing like actual implants that have been taken out of people. So if you're really squeamish, maybe just listen.
I picked they're
not gory.
No, I picked the least gory picture I could find. This is the best case scenario.
Yes,
so
clean.
From here, it goes really bad.
Yeah.
And I was tempted to put the gory one on there, but then why be salacious? And then it would make people feel very uncomfortable. So
good.
Yeah.
No, this is actually a really smooth capsule.
Right. So it's the capsule forms a barrier around the implant. Amy, so what do we think makes the capsule around the implant, at least in the body? If you're talking about cells in your body that helps us wall off foreign bodies.
I mean, it's a lot of things, but primarily it's going to be collagen matrix.
Right.
So it's really strong. It's really tough. Almost like when you're not to gross anybody out, but if you're cleaning chicken or meat, you have that really tough kind of silky layer of stuff that's actually fascia. But the capsule is kind of like that. It's very smooth on the inside of it, and it's very, very strong.
Right. So, and the cells most likely would be fibroblasts. Fibroblasts make collagen. These are the same fibroblasts that make collagen in your face. So, and we'll talk about that too, or we do talk about that. And they serve a lot of functions, but what they do is these cells that recognize a foreign body come in And they release all these chemicals, and we'll talk about those today, cytokines. Ultimately, the fibroblasts come and they create this collagen matrix or this scar tissue around this implant and wall it off.
Yep. Like weave a little basket around it.
The body's pretty amazing if you think about it. I mean, it's like, okay, we have a foreign body here. We got to wall it off. I mean, it literally walls it off. It's like surrounding something in cement. So,
well, it's not hard like cement.
I know,
it's
but
like
you get
putting
the
a net
idea.
around it.
It's-
It's cast in a net.
It has a sci-fi feel to it. Now, the problem comes ultimately is that we have a concern that implants we put in can have contamination on them. They can have sterile particulates, okay, which means that things related to the manufacturing process, they're sterile, they don't have bacteria in them, but they're not the implant itself. Or we can even have contamination with bacteria, and that's all different types. The type of bacteria that you would get contaminated with in this type of surgery would be completely dependent on where you live. So if you're in Asia, you would have different bacteria than you would have in the United States, which is really interesting. And the body, when it sees or it detects a foreign body that then is contaminated with bacteria, it does not like that, okay? So what it does is it walls it off big time. This is what
Sends all the neutrophils.
yeah, neutrophils are the inflammatory cells, and then they attract the macrophages, and then the macrophages bring in the fibroblasts, and then you make collagen. It is a big inflammatory party, and it's not good. You can be a very fulminant or very strong reaction. We talked about in a previous episode, fulminant snow. Fulminant means really strong and nonstop, just keeps coming.
Yeah.
So this is where the biofilm theory comes in. Again, on YouTube, you can see that. It shows a breast implant and then a magnifying glass with little bacteria underneath it. So you get the idea what that's saying. Now, with that said, this is not the answer, the full answer of what's going on when people have problems with breast implants.
Right. And we kind of skipped a step. We talked about the capsule as being something that's natural and is going to happen, but what we didn't mention is that a capsule can become bad if you get capsular contraction.
I was going to get to that, but that's the next thing.
Yeah.
So in some cases, people can have capsules, scar tissue around the implant that is stronger than normal, that's thicker than normal, and then actually it can be visualized and palpated, or you can feel it.
Yeah, and it almost starts to proliferate a bit in that it continues that process. It doesn't just form its little net around it and stop, like, okay, good, we took care of this, let's move on to other bodily functions. It almost continues, or it starts back up. I mean, we've seen that in patients who, had no issues with their implants for maybe 10 years, and then all of a sudden, one started to get kind of hard, and then it really progressed from there. Like something in their body kind of triggered that reaction to start building more scar tissue again.
Right. And so some people, and we're going to get to that part, I keep saying the same thing over and over, it's because we really don't totally understand what's going on, but some people form really aggressive capsules, and that's called capsular contracture, okay? Now, we've known for a long time, or at least for a while, that the covering of the implant can affect if someone forms an aggressive capsule or not. What we've seen, at least above the muscle, that if you use a textured implant, that the rate or the incidence of capsular contracture goes down.
Yep.
And if you use a smooth one, it is higher. So the texturing on the outside of an implant is related to the silicone and the way that it's processed in the factories. By the way, silicone is made of silica. Where do we see silica, Amy?
In those little packets in veggie chips.
Okay, besides that, we see it on the beach. Silicone is silica, sand is silica. It's literally the most common compound in the world. And what they do, instead of it being crystallized like sand, they make it into elastomers or like more of a rubbery kind of substance. And it's been found to be inert, and the body does not react usually violently to silicone. It's used in almost every different implant we use, from pacemakers to knees to hip replacements and stuff like that. It's well known that the body can tolerate silicone, at least on a full body scale. Sometimes locally you can have some problems. So we historically have had textured implants, and that will be important coming up here.
Well, interestingly though, and if you look at the numbers of implants implanted, textured is a very small percentage of the implants used in the United States. It's a very large percentage of the implants used in Europe. In fact, it's almost like flips itself.
Right.
They almost never use smooth implants in Europe, and we almost never use textured round implants in the States.
And this is getting into the real problem with data and breast augmentation, is that everyone does everything differently.
Yep.
And the numbers are all skewed toward the location you are and what kind of implants you use and the manufacturer, et cetera, et cetera. We'll get to that though. Anyways, at least historically, we've known that if you want to decrease your chance of getting capsular contracture or aggressive scar tissue around the implant, you could use a textured implant. It is important to note that that's only true for above the muscle or a subglandular approach. It's not true for below the muscle. That evens out to about the same with smooth and textured. Okay, so when I went through training, which surprisingly was a long time ago, I remember them saying, Dr. Martin, it's very important to use textured implants. You can use it if you're doing any kind of breast augmentation above the muscles. So that has always stuck with me. But what we started to see is that capsular contracture did not follow or does not follow what you would expect it to follow. So if you could decrease capsular contracture, you could use a textured implant, right, Amy? Mm-hmm. And you should have less, in most cases, less capsular contracture. If you take a lot of care and avoid contamination on the implant, and we'll talk about how I do that during surgery, then you should have less capsular contracture in comparison to people that don't do that. And then ultimately, if you make sure when you're doing the surgery that you have a clean field and there's no bleeding, et cetera, you should have less scar tissue. But what we're seeing now is that's not always the case. Mm-hmm. There is other dynamics, there's other influences that are causing people to have scar tissue, more scar tissue around the breast implant than normal. And when that happens, we call something a Baker classification system. Again, you can look on YouTube, it shows it there. The Baker score, a grade 1 is not really visible and barely palpable. In grade 2 to 4, it gets worse and worse. And if you've seen a grade 4 capsular contracture, it's very distorting. Mm-hmm. It's very asymmetric. It looks really bad.
Yeah, it's not good. I mean, I think in the 11 years that we've been working together, there's really been one that I would say was an actual 4. That one was, and
that wasn't our patient.
No, yeah. When she became our patient, but she had not started out as our patient.
Right.
That was really that's the only time I've seen a 4. Usually people are in a 2-3. Okay.
So not to belabor the point, it's about, if you take all comers, and there's tons of studies, and I think I have some of them in here, but there's tons of studies. This is make up a number. 10% of all patients will have, at least a Baker classified amount of capsular contracture. All comers, mm-hmm. all people that have had breast augmentation.
Yeah, and some people don't
10%.
mind. I mean, that's kind of the funny thing. We've actually had a few patients who, they come in and they're like, "Ooh, like this, my breasts are sitting kind of higher all of a sudden." I'm like, "Well, you got a capsule." "Oh, but I like it." All right.
Okay.
Yeah. Okay.
I mean, so just taking our practice, for example, we don't have a capsular contracture rate of 10%.
Nope.
Not even close.
No.
Not even 5%. Probably not even 2%. I can remember 3 patients that I've operated on that had really notable capsular contracture, and all 3 of those occurred fairly quickly. Other than that, and I've been out a long time, and we should see a lot of patients coming in with capsular contracture. You don't see it.
Yeah, and to be fair, after a year, we don't exactly have a lot of follow-up with our breast aug patients, because it's one of those surgeries, once they're a year out and they don't need anything from us, unless they have a problem, we don't really see them again. A lot of people move, a lot of things happen. So we're not doing like some type of scientific data on our patients to be able to get an exact number.
So that's anecdotal, everything I'm saying. But you would assume at least some of those people would call up.
Yeah. Call or need their records or something.
So the problem is, we've always thought historically that it's just biofilm, meaning that you get contamination of the implant. We do a lot of different things to avoid that. And if you lower that down, that you would not have capsular contracture. And that's,
or you'd at least have less.
Less, and that's not true. So there's things going on with capsular contracture that we don't understand. And that's a difficult conversation to have with people when they come in. So for example, when I'm in surgery, I use something called a KELLER funnel. A KELLER funnel uses, it's a means, it's a kind of funnel. It literally looks like, for icing.
It's like a pastry bag.
Yeah, like a pastry bag. Okay, so
that's really what it. I mean, that's exactly what it is.
It's a pastry bag.
Medical pastry bag.
Pastry bag for breast implants.
I think they're about $400 each.
Which, by the way,
disposable.
If you ever want to, so it's basically made out of plastic, and it's a pastry bag.
Mm-hmm.
So I would imagine that the cost of manufacturing of this is probably $5.
Oh, I'd say less than that.
It has to be sterilized.
Yeah. Okay. So maybe $5.
Okay. So Allergan, which is a large company, bought this company, the KELLER Medical, in 2016, I believe, for $300 million. $300 million.
Yeah, pretty good to be the guy who came up with the
pastry bag for breast implants.
implant. Yep.
Yeah.
It's just like filling a cupcake. Just plop it in there, squeeze the implant in.
The implants come in a sterile container. You can soak the implants in antibiotic solution, which I have a slide on that. Then you put it in the KELLER funnel, and it never touches your hands. It never touches the skin. It goes through the incision. Again, go back to the breast augmentation episode to learn all about breast augmentation, the different incisions. So it's literally a no touch. You don't touch this implant. It's not contaminated, supposedly.
That's what I was going to say, hypothetically.
Yeah, hypothetically speaking. Also, we soak the implant in a triple antibiotic solution. That at some point was thought to be the answer for capsular contracture. I still do that. Bacitracin, gentamicin, and Ancef, 3 different types of antibiotics. You put in a solution, soak the implant in that. It makes me feel really good as an OCD person. It's soaking in antibiotic solutions. I let it sit there. I stop for a second and just ponder how many bacteria are dying in that antibiotic solution. This is what goes through my mind when I'm doing these cases. Then you put it in the KELLER funnel and put it in. So if it was just a contamination thing, it was just a type of implant thing, you could put this implant in and do all these things that are correct. And if you go on any plastic surgeon's website, they're going to tell you they do all these amazing things. They're going to tell you they use a KELLER funnel, that they use a triple antibiotic solution, that they have hemostasis, meaning they don't have bleeding in the area. I mean, it's just, I see this all the time in marketing. FYI, that's really good. I do that too, but that's not the full answer. You can do everything right and you can still get a capsular contracture.
Yeah, and rates of capsular contracture, as far as I know, have not so drastically decreased since the invention of the KELLER funnel.
That's why I love you, because you always bring me back to the main point, is that all these plastic surgeons that you go on their websites or you go on their YouTube channel and they tell you they're doing all these amazing things, the rate of capsular contracture has not been decreased. Until we fully understand what's going on, and we're having a better understanding now, and that's coming, we won't know the true answer for capsular contracture. And we may never have a true answer for it. Because this is what I want to get to with this discussion, is I actually think that it really is dependent on the person themselves.
I agree. And there actually are some doctors, some surgeons who are doing genetic testing on patients prior to specific type of breast implant surgery. Women who've maybe had issues in the past, to see if they are a specific type of methylator, meaning their body detoxes or handles inflammation, just to let them know, like, you know, you have these characteristics genetically. These are your biomarkers that would probably make you more prone to having maybe some complications from having any type of implant, breast implants included. You know, do you still want to proceed?
Right.
Yeah, so I feel like that's, though, I mean, there again, there's no proof on that. There's no scientific backing on those things. It's just people taking information that we are kind of getting, presenting it to a person and saying, you know, here you go, like, you might be more likely to capsule. But then again, we don't know why you got it we don't know that. So
ultimately, what's going on here is there's some sort of inflammatory process that doesn't stop, and the body keeps walling off or keeps depositing collagen. We know that for a fact. We know that maybe contamination does add to it, or a biofilm. We know that the plane or where you put the implant, above or below the muscle, will add to that. And we know that, you know, just simple things like good surgery, don't touch the implant too much, adequate hemostasis are helpful. But above and beyond that, we're kind of shooting in the dark. And the FDA, which is taking a more active role in all this stuff, is going to force these companies to really ferret out that information. They will. And that's coming down. I know that certain implants are being taken off the market in Europe. Things are changing. So I feel strongly that breast augmentation patients should feel comfortable that the future is bright for them if they're choosing to do the surgery, that information will be coming down the line. And we're going to talk about some of that. This leads us to another topic, which is a topic. Go ahead.
Let's just take a step back. So before we kind of finish up with capsular contracture, what is the treatment for capsular contracture?
Oh, that's a good point. So the treatment for capsular contracture, as far as we have right now, is surgical. Okay, so meaning you surgically remove the capsule. And for me, I remove all of the capsule. Right. So why would I leave even a portion of something in there that is abnormal? Could lead to an inflammatory process to continue even when you put a new implant in. Also, I always take the breast implant out.
And we don't put that same implant back in.
Right. And some people do that. I would highly advise, if anyone's listening to this podcast and has this problem, please spend the money and get a new implant in there, because clearly there's something around the implant that's causing this inflammatory process. If it's the implant itself, it's a biofilm, it's a lot of combination of things. Other things that we can do, Amy, is the asthma medication. Accolade.
And we usually do that after, when someone already has developed a capsule. If it's very, very mild, if we catch it right away, we'll sometimes try it right away to see if it kind of stops the progression of that capsule. But absolutely, if someone has known capsule and we're exchanging their implants, as long as their liver labs are okay, we will likely have them do a course of Accolade.
Yeah, so if we get a lot of revision breast surgeries, because that's the type of office we have. People want us to make them better. Okay, so they've been somewhere else and they come into our office. If they've had capsular contracture, I will actually, in many cases, put them on Accolade, ACCOLATE, and at least for 3 months, maybe 6 months. The one side effect of Accolade is that it can cause problems with your liver or increase your liver enzymes. So you follow those. If those increase, then you have to stop the medication.
And medication is used very commonly for asthma. So it's not like it's a scary medication. Like we just track your liver. There's a lot of medications where you track liver labs. This is just one of them.
I know. I mean, you're talking about elective procedures.
It is. It's true. Yep. That's what I mean. But it's not as scary as it might sound.
No, it's a common medication that people use all the time.
Very common.
And then that we don't know if Accolade. It's always been, or at least been believed historically, that Accolade the changes last forever. But there's other people that think that you could do the Accolade, get better or less capsular contracture the minute you stop it.
Still have one.
You'll still have capsular contracture, and it'll worsen again. We have not seen that with our patients. Again, that's anecdotal, but those are your answers. So 10% of all breast augmentation cases will have capsular contracture. Anecdotally, we have not seen that in our practice, but just put that in your head. The problem is if you've had capsular contracture, your incidence goes up even higher afterwards. So if you do a revision surgery, it's not like, and if your surgeon tells you this, they're wrong. It's not like your incidence is the same as the average person. Once you've had capsular contracture, you're at much higher risk to have it again.
Yes, which makes sense.
Not like higher, not double, 20%, 15,
no, but
whatever it is.
Incrementally higher. Yeah. And you're having surgery again. So you have to think you're starting that whole process of healing over just by the mere fact of having surgery again. So if whatever started that process initially, it could potentially start again. So those are all things to think about. Just so if you are considering breast augmentation, just know that capsular contracture is a known complication. It's obviously been studied a lot. We're still studying it. The solution is additional surgery. So that's it.
All right. So the thing that's been in the news lately, Amy, ALCL, anaplastic large cell lymphoma. And it's the full name is Breast Implant Associated ALCL. There was a 60 Minutes or something like that, Nightline.
Recently?
Yeah, recently. Yeah. I've had multiple patients come in and they've told me that they've seen this. It is related to breast augmentation. It is a lymphoma that literally develops from having an implant around your breast, or underneath your breast.
Right. There are no cases of this specific cancer that are not directly related to implants, correct?
Right. Now, there is a variant of ALCL that's called cutaneous ALCL, and that's in the skin, what cutaneous refers to, and it's very similar to this, but it is different. It's not the same type of lymphoma. Lymphomas are divided into Hodgkin's lymphoma, and that you see those in kids a lot. In college, I had a classmate who had Hodgkin's lymphoma and non-Hodgkin's lymphoma. Non-Hodgkin's lymphoma, of all lymphomas, is usually more aggressive than Hodgkin's lymphoma and less treatable. The good thing about ALCL is that it has a very, very good prognosis. So we've established that with capsular contracture, or what happens when you put an implant in is you form a capsule. Unfortunately, that process of forming a capsule can lead to a situation where you have lymphoma. Guess what the incidence of this is, or the number of cases we've recorded in the history of breast augmentation?
I think there's 300.
It's almost up to 400 now.
400.
Okay. So I just want to state clearly that this is a rather rare occurrence.
Mm-hmm.
Okay. So anyone listening to this who's had breast augmentation, please understand that the likelihood of you getting this would be pretty small.
Oh, it's far less than just developing breast cancer. Far less.
Far less. If you look on our YouTube channel, you can see a breast tissue, and then it shows a fibrous capsule, and then you get this fluid around the implant, and it shows a lot of fluid there. It could be a little bit of fluid, and then within that fluid is lymphoma cells.
And it was the theory of how this fluid could develop late, after the implant has been in, maybe 5-10 years later. I mean, obviously the body has ways of getting through this capsule even after it's been well formed, because it's constantly rebuilding it also, like anything else in your body. Is that then how this gets there? Yeah,
so they don't really know. The idea they first thought was the biofilm theory that we talked about with capsular contracture. Now they're not sure about that. One caveat of all this is that they've never had a case, to my understanding, of ALCL with a smooth breast implant. It's only textured breast implant. So there's something with the texturing of the breast implant, something with the capsule formation, maybe a biofilm, that leads over time to these cells to develop lymphoma cells, and we'll get into how that occurs. The process of which that occurs, if it's going through the capsule or it's within the capsule, they don't totally know. What they've done is taken cases now, they're creating a bank of these capsules they take out during treatment of this problem, and we'll get to that too, and they've analyzed that for the cells in there and looking what's going on.
Mm-hmm.
And what they're really seeing with that is they think this is primarily an immune response, not just a foreign body response. And it's regulated by T cells. T cells are, people may know with HIV.
Mm-hmm.
We talk about CD4 counts. With HIV, if your CD4 counts, or that's the number of T cells floating around, gets really low, I forget what it was, less than 250 or 400 or something, then you can be diagnosed with AIDS. So this is the same cell that goes around. It's the primary cell in immune responses.
Yeah, it's like your defensive cell.
Right.
Yep, the fighters.
So I remember one time trying to explain it to a patient. I said that the T cell was like the foreman on a job building a skyscraper, and it's just going around putting out fires the whole time.
Yeah.
And it's telling people what to do. Like, hey man, that foundation's about to crack. More cement there, over here. And those are the cytokines. Those are the chemicals these T cells put out. T cells themselves also change into different types of T cells. It gets very, very complicated. Reading up for this podcast, I realized there was no way I could describe this to any sane person who hasn't been to medical school. And even talking to doctors about it, they probably wouldn't understand.
No, it's funny because I actually have this massive, massive diagram from school of like basically the functions of the immune system. And oh my gosh, I mean, like it was done by a guy who did the whiteboard drawings, and like he literally had drawn like all the T cells as like these little like tanks, because it's kind of like the tanks go here, like blow something up, and they go over here and like blow something up, and like people come in and like fill stuff in behind them. And it was like the best way to like show it. But I mean, it literally is an entire page full of like basically one process.
I know.
Yes.
So yeah, T cells are like mad dog Mattis, telling like attacking anything that's going to attack you.
Yes.
What we think happens is you put the breast implants in, and this is the historical theory, is that the breast implant gets contaminated. Okay, so it either gets contaminated when you put it in on the skin, or the endogenous bacteria that are in the breast. And this is why they always had a theory of, so why would you have an increased incidence of capsular contracture above the muscle and not below?
Because it's closer to the glands.
Right. So the glands, the ducts, have bacteria. We've talked about that before on this podcast. The bacteria in the ducts of moms gets passed along to the kids, and that's why they start having immunity. It's from the colostrum and breastfeeding. So those same bacteria that are in the glands can, from an endogenous standpoint, contaminate an implant. The same thing is on the skin and externally at the time of surgery. So they believe that there's a biofilm that's created. You get this low grade, what we call indolent, which is like a slow burning fire, that infection, and that your body, it creates inflammation. And over time, that inflammation keeps going and going and going and going, and then you get ALCL. But it's not that clear cut. The biofilm may not even be a part of this process. They still are trying to figure out why the texturing does make a difference. They've shown that some textured implants have higher incidence of ALCL and some do not. So we have, on one hand, we have capsular contracture, which we have said that having a textured implant is helpful. And then on the other end, we have ALCL, which is the same kind of process as capsular contracture. And we found that the textured implant is really bad, or at least from a standpoint of ALCL, it's bad.
So what's the mechanism?
Are you
there?
confused? Yeah.
Yeah.
So the mechanism, they're not totally sure. There's some antigen, okay, which is a foreign thing. That's either bacteria or something related to the texturing that the body reacts to. So the mad dog maddest T cell from the thymus comes in and says, hell no, I don't want this antigen anywhere near my body. I'm going to go from a native or naive T cell, a T helper cell, and form and go into a T cell that's, they said Th17 or a Th1. And these are inflammatory T cells. These things create inflammation. And that process just feeds on itself and feeds and feeds and feeds. And what happens over time with inflammation is that it creates problems in the T cells. It activates oncogenes, and then ultimately you get lymphoma or cancer. The T cells start to act abnormally.
Yeah, and I think that's kind of an important thing just to state, you know, for people who may not understand, like all cancers essentially in the body are a mutation of a cell that's already there. It's not like a sickness. It's not an acquired condition. You can't acquire cancer.
Well, you can't. No, you can. There's viral infections that can lead to cancer.
That's true.
Okay.
That is true.
But the cancer, the virus affects the cell.
That's what I mean. The cell's already there.
You can acquire cancer.
Yes, you can. Like
HPV.
Yeah, that's yeah. More my point meaning, like I think somebody's afraid that like their implant somehow brings this cancer with it.
No, that's a good point.
That's not the case.
Yeah, there's not cancer surrounding the implant. It's your body changing,
acting freaky,
Yeah.
like freaking out, and the cells start to proliferate in a way or copy themselves in a way that's abnormal. But it's not like the implant itself is bringing the cancer into you.
And they have found mutations, the JAK or STAT3. They kind of know what's going on. They when they get the ALCL, they can do all their stains and figure out what the cell line's doing. They just don't know. They don't really know totally which antigen does, that's presented to the T cells. The T cells go crazy. They don't really know that part.
Right. And confounding it more, the whole textured versus smooth implant. I mean, there's a lot there that's confusing.
Very confusing. To the point that I've been to talks on this ALCL before it got into the news, and listening to the experts, they would just give a talk like I'm giving a talk right now. Well, we don't know this, we don't know that, we don't know, but these are the things we know. These are the things you can do, which is really just keep on doing what you're doing right now. Ultimately, the T cells make cytokines, and the cytokines are the chemicals that cause inflammation, chronic inflammation. If you look at TGF-beta, IL-11 or 12, I mean, there's different cytokines that cause this. And if you're interested, again, look on our YouTube channel. We can show you all this stuff. I would highly advise people to research this, but it gets very complicated and probably will gain you nothing if you're considering a breast augmentation.
Because at least at this point, the risk is so low.
Quick facts, it presents at 9 years. Some people get ALCL quickly. Other people get it really delayed. We've only seen it in textured implants. It has a slow course. It's locally invasive. It will not cause systemic invasion. All right. So unlike non-Hodgkin's lymphoma that goes all throughout your body, this is only local within the area around the implant and in the local lymph node bed. So if it's your breast, maybe it would be in your armpit.
Now, see, how can it get to one set of lymph nodes and not travel beyond that? Like, how can they know that it can't travel beyond your first lymph node?
So the prognosis with this is greater than 90% survival. So it's a local issue, right? But there are 10% of the people that have serious problems, and maybe those people become a little more systemic. I didn't read up on that or look at case studies because, again, the numbers are so small, but at least for what we know, it does not travel outside this local milieu, all right? The treatment is really fairly simple. It's removal of the implant and complete removal of the capsule. You go to an oncology team. In some cases, you'll have chemotherapy, and you get followed for 5 years. The risk varies all over the place. Allergan's risk with their textured implants is more common to see ALCL. In terms of Mentor, which is another manufacturer of implants, their incidence is more rare. And Sientra, but
these are self-reported, though.
Self-reported, and also they're following them at different times. There was a study in Australia and New Zealand. I mean, it's like it's a mess out there in terms of trying to figure out what this data means. But just know that we have 400 cases. It's between 1 in 3,000, as we know right now, 1 in 30,000. At least that's what the FDA wants us to report. We still don't know the true incidence. And there's no current susceptibility test. You can't, if you're considering a breast augmentation, you just can't go get a test that says you're at risk for ALCL.
Right. How is the diagnosis usually done?
Yeah, so the diagnosis, real quick on the symptoms, because the symptoms are really important. So if people listening to this, if you're concerned about ALCL and you've had breast augmentation, breast enlargement, breast asymmetry, pain, swelling, breast or armpit mass, that would be increased the size of the lymph nodes. Some people get a rash and hardening. And a fluid collection is really kind of the big thing you would see. That lymphoma fluid that we showed before and talked about before surrounds the implant. So what you would do there is you would do a physical exam. You would go to your doctor. He would say, yeah, I kind of agree with you. You have some symptoms here. We're a little bit concerned, not sure what's going on. The first thing you would get is an MRI. MRI can tell you with high assurity if you have fluid around the implant, you have a problem with your capsule. You can really visualize the soft tissue in the breast implant itself. Then you actually stick a needle in with ultrasound guidance and aspirate out the fluid that's there. And then they stain that fluid, and they can find the lymphoma cells in there. And we've done that before. I mean, we've talked about that. We had a patient of ours who had a history of breast cancer, had a breast implant in place, had fluid there. I was concerned about ALCL, but she actually had a cancer recurrence, unfortunately.
And then we had another patient who had a kind of a sudden onset of some fluid. It ended up being nothing.
Right. So if
Hers was just inflammatory.
If you have like quick swelling of the breast and it's related to fluid, any board-certified plastic surgeon should immediately get an MRI on you and then also test that fluid for ALCL. Diagnosis and management, we said that before. You have to remove the entire capsule, remove the breast implants, and I'm assuming they don't put other breast implants back in.
I would think that anyone going to a reputable surgeon would not take that chance of putting an implant back in.
That would be insanity. I mean, I guess theoretically you could put a smooth one in, but
what if they already have,
Yeah, you know what I'm saying? So since you don't really know what's going on, you would take the breast implants out, leave them out, do adjuvant therapy, which is usually chemotherapy, and they would follow you for 5 years. And the following would probably be MRIs, to be honest with you.
I mean, it just seems like I can't imagine a woman wanting to put an implant back in at that point.
Yeah.
Or a doctor who'd be willing to take that risk of putting an implant back in.
All right, so that kind of sums up ALCL. So 400 diagnosed cases. So anyone out there listening, please understand, this is extremely rare. It's only been diagnosed with people with textured implants. A majority of the implants implanted in the United States are smooth. The only time I ever use textured implants is for breast reconstruction. And that's specifically related to anatomic shaped implants. So the texturing on those anatomic shaped implants theoretically could lead to ALCL. In terms of round implants or implants, if you just wanted to get a breast augmentation, rarely would I use texture. But Amy's absolutely right. In Europe, they use textured all the time. Now, in Europe,
the norm.
They just took all the textured implants off the market. So the governing body there, specifically in France, and they're a little bit sometimes more reactionary, but they said, you know what, until you guys can, or not all of them, the Allergan ones, and they're going to do the same to Mentor, I'm sure, and probably Sientra, I'm sure. They want more data. And I'm sure that the FDA is going to probably follow suit here. So in our practice, the only people that's going to affect are the breast reconstruction patient who really benefit from a anatomic shaped implant. In most cases, if you have at least an ample amount of breast tissue, or at least some breast tissue, you don't have to do an anatomic shaped implant or teardrop shaped implant to have really good outcome.
And in fact, they can give an appearance that most women are trying to get away from.
Yeah.
Of a bottomed out, heavier breast.
Right. You're like doubling down on the thing that most women
that you
hate.
don't like. Yeah. So it's kind of a funny thing. So women think they confuse a natural looking breast with an anatomic implant, and they're not the same, like at all. Most women don't want more lower pole fullness.
The one thing I'll tell you that's going to come out of this is that texturing is going to be used a lot less besides breast reconstruction. So that's different. So if you're going out to get a breast augmentation and you want an anatomic shaped implant that's textured, I think that's, reputable surgeons might try to talk you out of it.
Yeah. Yeah.
Just for the mere fact of ALCL and what we're starting to understand with textured implants.
Mm-hmm. And that they don't really, for a primary breast aug, give most women what they're actually looking for.
Right.
So I think that's also there.
Next.
So we talked about the treatment for that, so we're good with that one. So breast implant rupture is such an interesting thing because
that's the main thing. So if you think about the questions that people ask when they come in, what's their biggest concern?
Rupture.
Yeah.
Yeah, that's what everyone's worried about. And I mean, we have seen some crazy things over the years. Like the woman who had those implants that were put in like the early 80s that were like surprisingly still looking like an implant, but I mean, it was like pulling honey out. Like, I mean, it wasn't even like, it's nothing close to what silicone is like now.
I know.
So, I mean, that's rupture, I think, doesn't mean what it used to.
So you have saline implants and silicone implants. Saline implants are filled with saline, which is basically water, and silicone implants are filled with silicone. Now, both saline and silicone implants have silicone shells.
The shell is the same.
So everyone comes in, they're like, I want saline implants because I don't want silicone. And I'm like, you're getting silicone no matter what you pick. Mm-hmm. Saline implants are inferior, period, end of story. They're cheaper. That's why some people use them. But if someone tells you that saline implants are great, at least up to this point, they're not. Silicone implants are far better. They have more durability. They have less rippling. They have
better, feel better.
Yeah, they have less rupture rates.
More durable.
Yeah, more durable. So I'm talking about breast implant rupture rates with silicone breast implants. And again, the data is not that great on that either.
It's not.
Gosh.
Because it is also self-reported.
Right.
So unless these implants are returned to the manufacturer doesn't even know if there was a rupture. They're basically just taking the doctor's word for it. Was it a shell failure? Was it an actual rupture? Was it a mechanical rupture? You don't know that. So
saline implants, they don't last as long, but when they rupture because your breast deflates basically.
Yep.
And at least with a saline implant, for sure, you can actually have a trauma that could cause a rupture. Mm-hmm. You could get in a car wreck. We live in Colorado. People ski. You could ski into a tree and come out with one smaller breast.
Well, that, and they inherently kind of wear.
We're laughing a little bit, but I've had that patient, and I felt terrible for her. And she was like, I don't care about my broken ribs. What are we going to do about these implants?
Well, and conversely, we had a woman who was kicked in the chest by a horse, and her silicone implant was fine.
Yeah. So the silicone is going to be a little more durable, and you need to go back again and listen to the episode on breast augmentation because it talks about cohesive gel, or the new types of silicone gel that we have. Those things are pretty amazing, and I have a picture in here. You could cut them in half and they won't lose their shape, and that's exactly what Amy's talking about. The silicone implants of the 80s were like warm jelly.
They were liquidy.
And now these are a lot more consistent and not liquidy. So even if they technically rupture, a lot of times the silicone won't go out and it won't deflate.
Right.
It'll kind of hold its shape a little bit.
Yeah, the shape will stay the same. In fact, most women with a silicone rupture don't know because the shape does stay the same. It's probably diagnosed on routine scanning.
So we're showing a chart here just on rupture rates, and it talks about the Kaplan-Meier rates, which gets into statistics. It's like medicine can never do anything to straight up. It has to be a Kaplan-Meier rate. Anyways, just imagine that the likelihood of you having a ruptured implant is small. It's definitely less than 10% across all implants. But it will depend on the type of implant you use, shaped or round, and it will depend on the manufacturer. We've had one ruptured implant, and we sent it to the manufacturer, and it was actually both sides. Wasn't it? Or it was one side?
It was one side.
One side.
It was almost exactly a year to the date. They
Yeah.
were very new implants, and Yeah, that
Yeah.
was surprising.
And, surprise, surprise, the manufacturer said that it was probably related to the surgery.
No, that's not. You're thinking of the saline. We had a saline deflation.
Yeah.
That one they said was perforated when we did the mastopexy. The woman who had the double wall failure, hers we sent back in. I mean, remember, I have pictures of it. Like the shell, like it was like completely
Right.
had
That was
pulled
my
away from
point.
itself.
You send these back to the companies and they do their scientific analysis,
Yeah.
which then they come back and say it was probably related to the surgery because they don't want any financial liability with it. With that said, I mean, it's fine. We took care of business. And
No, they paid that one, the recent one.
of course they
paid for.
pay. Yeah, they pay for it. But
Yeah.
then they write the legal documentation that says somehow they weren't at fault. With it said, I mean, all that matters is the patient was better and they were better and they're fine.
And now it's been like 5 years and her
Yeah.
implant's fine. So
Right. But
it's a freak thing.
we don't. The reason the implants fail is because either it's a manufacturing error, that the implants are folded or rippling, and that's why salines tend to fail more. And the area where it folds or ripples is where you have a weakness in the shell of the implant, or it's something related to surgery. And they think that at least 50% of the implants are damaged at surgery. So for our practice, again, anecdotally, we've had minimal to no incidents of rupture. We've had one or two. The saline one, I don't remember, because if you rupture a saline, you should know right away.
It was within a few months.
That doesn't make any sense.
I know. That's
Yeah.
why it was
That's
so
BS.
funny. I mean, it would
Yeah.
have deflated immediately.
Yeah, it doesn't matter. So anecdotally, in our practice, we haven't had this very often. But is that because we've been lucky, or is that because we have healthy patients, or I don't know. Technically, we're not damaging this during surgery, but about 50% they believe, that's the number they shoot around, is related to surgery, meaning that the implant somehow is damaged at the time of surgery.
Well, that was one of the Keller funnel's big selling points, was that you could, because doctors were manhandling the implant essentially, like they were being too rough with it, where the Keller funnel claimed to keep consistent pressure on it the entire way so that you wouldn't get like deformities from squeezing it too hard. Like
Allergan Medical
Yeah.
believed that claim, and they paid $350 million for a $5 funnel that you could have bought over at the Piggly Wiggly or whatever.
Michael's.
Yeah. So implant rupture is a real problem. Again, less than 10%. It's becoming less of an issue just because most of the implants we're using now are silicone and cohesive, which means they hold their shape. I have a picture of that too on the YouTube channel. You can see it looks like a pie. The silicone will not leak out like a fluid. And so the only way to know for sure in these kind of situations is to get an MRI. And just like with capsular contracture and following ALCL, the MRI will tell you if the implant's intact. Very sensitive. It's almost 100% assurity it's going to tell you if it's ruptured or not. So implant rupture is the least controversial topic we talked about today. Capsular contracture is kind of the middle one, and ALCL is like hot button issue right now.
Yes, it is.
And the reason why ALCL is the most hot button issue is the least we know about. Capsular contracture is right behind that. I think that implant rupture is a reality of any implant filled with something. You're going to have some cases where the implant fails. And you're going to, no matter what the manufacturers say, you're going to, I mean, you can't manufacture everything 100% perfectly. So you're going to have that one instance, albeit small, where the implant is not perfect.
Right. Like we had with that patient. I mean,
Yeah.
it was clearly a lemon, I guess,
Right.
to use a common term, but because clearly she's had the replacement implant in for 5 years now and has no problems with it. So it was a fluke occurrence.
And we deal with these companies, Allergan, Mentor, and Sientra, and they take it real seriously about the manufacturing process. The FDA comes down really strong on them. So to their defense, they are doing what they need to do, but you can't be 100% perfect, especially if you talk about huge numbers and how many people are getting breast augmentation every year. Hundreds and hundreds of thousands of people in the United States, at least, every year. All right. Any other controversial issues that we missed?
Well, I think the most probably recently publicized controversial issue is breast implant illness. And this is something, if you are on YouTube, you've probably seen someone that you follow talking about this. And
Who do we follow on our Instagram account?
so many people, but you mean specifically they've done it. Emily Duncan is one.
Yeah, M-Dunk. E-M,
Dunk.
like lower, what is that? Lower hyphenation?
Yeah, underscore.
Underscore D-U-N-C.
Yep, and also A New Leaf Fitness. I mean, there are a lot of fitness competitors that we follow who have, recently come out having their implants removed. There are several others I've followed, and this has, been in the course of the last few years. And the theory behind breast implant illness kind of ties into a lot of what we were talking about with capsular contracture formation. Just that there is inflammation caused in the body, and your body is basically just not happy having the implant there. Now, women are having a range of symptoms that they're really, kind of finding a correlation to their implants, fatigue, other systemic kind of seeming issues.
Like what? Like swelling or?
Brain fog.
Yeah.
Digestive issues, weight gain, like so many things, mood disruption, like a lot. The list of things that women are, kind of claiming are symptoms coming from their implants is pretty long. And for some women, they have their implants out and they literally, like the next day, say that 99% of their symptoms are completely gone. And we're great, So we would never say to someone that wasn't their experience, correct? Because as we've clearly already found, that yes, you can absolutely have inflammation from any type of implant, be it a hip, be it a breast implant. Like that can cause a chain reaction in your body of things that are, not happy. However, we have years, decades of experience with women with breast implants and have not seen that there is an actual pattern there, at least not that we have identified.
Right. And there was huge studies. There's a nurses study. You should go back and look that up in the 90s. There's a breast cancer study where they looked at people with breast implants, and they've shown the safety related to autoimmune disease, et cetera, et cetera. But there's obviously something there with these patients. The unfortunate part is we don't have a lot of scientific data. And the other unfortunate part is that the internet amplifies bad information. And so people will read things and automatically self-diagnose themselves, and which is understandable. We all do. I do that.
Right. But the solution is surgery, to these women. So I feel like there is legitimacy, and these women are not just like, oh my gosh, my implant's out. Like,
I'm agreeing with you. And even theoretically speaking, and I think there's something there that me professionally, but I'm one person, just say there's not, and they do surgery and they get better. Say it's a placebo effect.
Yeah.
So they feel better. All power to them.
Exactly.
Right?
And we ourselves as a practice have had one patient who was referred by her rheumatologist. Actually, no, there'd been two whose rheumatologist specifically told them that their implants removed. And we did, and they're great,
Yeah.
They're happy. And that's kind of the hard thing, is that because there has not been any research on this that's really definitive one way or the other for this range of symptoms, because removing the implant seems to fix it, it's hard to say.
If you're someone who's struggling, you should definitely see your physician, maybe see an endocrinologist. Try to really exhaust all the options you have. Unfortunately, most people won't understand what you're even saying, but there's more information coming out, and considering removal is always an option. And so the reason that you would not do removal is because any procedure has risk. I can tell you that we do in our office removals under local anesthesia.
It's really easy.
It takes me how long?
Well, but to be okay, so let's
I know I don't want to minimize it. I don't want to minimize it.
I'm just saying that when we do a removal like that, we're only taking out the implant. We're not taking out the capsule.
Right. So
and women with breast implant illness are very adamant that they have to have en bloc.
Right. I know.
Removal.
I was going to say that.
Yeah.
So for just removal itself, it's 20 minutes.
Easy.
If you have breast quote unquote implant illness, BII, which is not technically a medical name right now. I just want everyone to understand, at least in the modern literature, but it may be, then you would want to take the capsule out and you would want to take the implant out exactly like you would do for removal of a capsule around an implant for breast augmentation, revision, or especially what you would do for ALCL treatment,
right,
like we talked about today.
Because it's likely that capsule is essentially what is causing your body to have some of these inflammatory
something in that
responses.
capsule, which we don't know.
Right. But I think it's something important too. Like if, it's just good information to have. If you are a person who is looking to have any type of implant put in your body, a breast implant or otherwise, if it is elective, you need to understand that there are still risks. Just because it's elective doesn't mean you're free from risks of surgery or risks of complications or risk of adverse events. There could be risks with anything. So I think just being informed and understanding that just because this is elective and the safety record is extremely strong with this. Because
again, it's one of the most common surgeries we do. Hundreds of thousands of cases a year. We've been doing this since the 70s or late 60s, and there is millions and millions of patients who've had breast augmentation who are doing just fine.
Yep, who are asymptomatic, have no symptoms of anything.
Right.
And live and die with their implants in place.
I will tell you that it does You do feel for those patients though that are, and that's few and far between, very rare. But when you like read what M. Dunk was talking about on her Instagram feed, or we've talked to a few patients, that we've helped out, you feel for those patients.
Yeah.
And I think that's...
It's not like they want more surgery.
No. And I feel like this is a topic that should be talked about more in the field of plastic surgery. Again, this is a for-profit business. People don't want to always amplify things that could go wrong. But since this is an educational podcast and we're not trying to make profit off of this, I think it's important to give patients this information. But you always have to put information in its proper position or context. And the numbers that we're talking about here across the board are extremely, extremely small. If you are considering a breast augmentation, you should listen to this podcast because it will educate you. But I feel strongly, and I would recommend this to my wife, my mom, or a female family member, or even Amy. If they were going to have a breast augmentation, I could tell them if you go to a board-certified plastic surgeon that does proper technique, proper sterility, uses the $350 million KELLER funnel, and has adequate hemostasis, and uses the triple antibiotic solution, and has proper care afterwards, and you don't smoke cigarettes, and you decrease the drinking around the time of surgery, and you're healthy, that you should be fine. I can say that with 100% confidence.
Okay. I think I have nothing left to say.
Okay, that's good. Hopefully people enjoyed this episode. This was a lot more scientific. That's why I wore my scrubs, because I was going to drop the science. What does Lane Norton always say? Make America Science Again.
Oh, yeah.
What was
Like he says a lot of things.
Yeah, well, not the salacious, controversial stuff. Yeah. So we were dropping some science today. If you want to have more information on this, we're going to be putting some blog articles on our website, Jason Martin MD, specifically related to ALCL. I'm going to be writing that. Also, you can watch this episode on YouTube. It might be helpful because we do have a lot of visuals, and there's great articles actually on the internet in regards to things that have been published in specifically in plastic surgery journals that I've read. If you really want to get into it, you can kind of get into the real data that's there.
You can. And be sure to follow us on Instagram and YouTube at Jason Martin MD, and also at Beauty and the Surgeon Podcast. Please rank us and review us, share us with your friends, and leave us comments. Like, we really do want to know what you guys want to hear about. If you like this podcast and you have questions, please ask them.
I think the last and most important thing is just you need to talk to your T cells. Say like, just relax a little bit. You do not need to be inflamed here. We do not need to have a problem.
Chill out.
Yeah. Do some meditation with your T cells. Okay. Thank you.
Thanks, everybody.